Good afternoon, everyone. Welcome to our wonderful event we've got today, our Moving People, Moving Research event. So firstly, I'd just like to acknowledge the traditional owners of this land where we're meeting today. Today, we're on the land of the Gadigal people of the Eora Nation, and I pay my respects to elders past, present, and emerging. So I'm Leanne Hassett. I'm one of the associate professors here in the Faculty of Health, of course, the Sydney School of Health Sciences. And I also one of the implementation science leads from Sydney Health Partners. And I've just recently taken on the convener role for the Faculty Academic Implementation Science Network. So this is a very collaborative event and co-badged with lots of different organisations which all share a passion for some of these similar research interests. So we're co-badged so with the Implementation Science Network and also with Spartan, so the Sport and Physical Activity Research and Teaching Network. And Associate Professor Melody Ding is co-chairing this with me and will take over at the end of this. This is also being conducted with Sydney Health Partners, with the Musculoskeletal Clinical Academic Group and the Prevention Research Collaboration. Just a few housekeeping things first. So we're going to have a Q&A session after Heather's presentation. So we're going to be using Slido. Many of you may have used that before, so you can get out your phones and get the QR code. And there's the event code there. We will put it up again later as well, so that you can put your questions in, and hopefully we'll get to it during the Q&A session. Just letting you know that we do have some face masks outside if you'd like to wear one, and just thinking about the standard maintaining social distancing. If we have an emergency, which hopefully we will not, then I encourage you all to use the stairs safely, and the evacuation place is the oval over there. We also Twitter. I know there's a few Twitter people here, so if you are, then using the hashtag Moving People. All right, so we've got a wonderful hour ahead of us of presentations, and then we're going to have a networking session after that. So I really encourage, if you're able to stay around and network with, meet some new people and catch up with old friends and collaborators. Right, so first I'd like to introduce, on my right bit, Dr. Karen Lee. So Karen is a research fellow at the Prevention Research Collaboration, and she's going to be talking about, is scale up happening? So thank you, Karen.
Thanks, Leanne, and thank you everybody for having me here today. It's such a privilege to be part of this seminar. Today I'm going to present the findings of a bibliometric study on published physical activity literature, which is important for us to understand what types of physical activity research is being done and whether that research is actually helping us scale up or not. But before I go any further, I'd like to acknowledge the traditional custodians of the land of which we stand on today, which is the Gadigal people of the Eora Nation. Okay, so fairly self-explanatory, but why do we need to scale up? Well, quite simply, we know that there are risk factors that contribute to chronic disease that affect our whole population, things like unhealthy diets, physical inactivity. So if we want to tackle and address this issue, we need to be delivering interventions at the population level. And in order to help us do that, we need research that promotes or facilitates scale up. So to help us understand how research can actually promote scale up, I just need to turn your attention to a fairly simplified research translation model. So first of all, when the problem isn't very well known, we will conduct descriptive studies to understand the problem. Things like prevalence studies, cross-sectional studies, we interrogate the data to tell us what the magnitude of the burden of the problem is. And once we know what the problem is, after doing these descriptive studies, we need to start addressing the problem. And we start addressing the problem by developing solutions and then testing those solutions to see whether it works, usually on small pockets of the population. And then the next part, this is where the real sort of process of scale up starts to happen, is that once we know something works, we need to replicate it into different parts of the population, test it, adapt it, modify it, and then we scale it up to the entire population. So we need to understand whether it can work in the real world with the whole population. And that's how we might start to see population level impacts. Okay, so as I mentioned, descriptive studies are really useful in helping us understand the problem. But once the problem is well known, for example, we know physical activity is a real risk factor for chronic disease or obesity, to continually do descriptive studies is not particularly useful. We actually need to do something about it. And that's when we need to start conducting evidence generation research, intervention research that actually tells us how we might go about solving the problem. So what are the trends in the physical activity published research telling us? Ideally, we would like to see sort of the proportion of descriptive studies in published physical activity literature sort of being around, maybe a fifth. However, a study in 2008 found that up to 85% of published literature in physical activity was descriptive, and only up, as small as 15% were intervention research. Another two studies in 2011 and 2016 found very similar results. So up to 76% and up to 89% in the 2016 study, but this was sort of all across public health. So as you can see, what it's saying is we're very good at describing the problem. We're not so good at doing something about it. So in summary, the dominance of descriptive research is a real matter of concern. As I mentioned, why? Because the problem described is not being addressed. Research translation isn't occurring. Scale up certainly isn't happening. So we need more evidence for action. And even within intervention studies, I guess you could say not all intervention studies are created equal. Effectiveness studies are really good, as I mentioned, at testing interventions in a small scale in controlled settings. But to actually really scale up, we need to be doing replication and dissemination studies. But a study in 2011 found that even within that sort of small number of intervention studies, in 1988-89, all of them were efficacy or effectiveness studies. So meaning that we're really focused on just testing interventions on a small scale. 10 years later, this trend is still fairly similar. You see a 2% of studies there were coded as replication studies, and really it was just one paper. And then, another 10 years later, you start to see the trend shift a tiny bit. And this is the first time that you start to see dissemination research really appearing in the physical activity literature. So it's taken a long time, and it's still, very, very is negligible. So I've mentioned this already a little bit, but efficacy studies and effectiveness studies are great, but at the end of the day, they are done in small samples, the small sample sizes, small settings, and largely under fairly controlled settings, and therefore their results have limited generalizability. They don't tell us a lot about the potential scalability of the intervention or the likelihood of scale-up success, or even sustainability if it's been scaled up. So this study was about extending the findings of the previous studies to see whether in 10 years later, has it changed? And how we did this using bibliometric methods. Unfortunately, what did we find? We did not find anything too dissimilar to what they found before. So more than 30 years later, we are still finding that descriptive research dominates the public physical activity published literature. Within intervention studies, however, the story isn't very different, but we are starting to see a bit of a shift. We are starting to see some shift towards increasing numbers of replication and dissemination studies being done. And dissemination studies do actually reach a bigger proportion of the population, because when we looked at the sample sizes of all these studies, we found that dissemination studies definitely on average had much higher sample sizes. So we need to be doing more dissemination studies. So to summarize our key findings, essentially, as I mentioned, not much has changed. As a community, we're still doing a lot of descriptive research. It's still dominating the published literature in physical activity more than 30 years later. There is some promising trends, but it's very slow. And within intervention research, we are still predominantly focusing a lot of our effort in testing interventions on a small scale rather than actually looking at conducting scale-up studies. But all is not lost. What we did find that was interesting was that there was evidence of more thinking around scale up and implementation size and how we implement things. Then we found an emergence of this category of papers, which we coded them as conceptual papers. And there were things like introducing new frameworks and processes or concepts, methodologies around scale up and implementation science. So at least we're thinking about it. So let's hope that if we were to replicate it in another 10 or 20 years' time, we will start to see a much bigger shift. Okay, so I'm just going to end on, so why are we not sort of conducting dissemination research? Well, quite simply, cost and time. Cross-sectional descriptive studies are much cheaper to do and quicker, and we can publish them fairly quickly. There is a perception that, oh, well, actually it's not perception. Funding agencies do tend to favor efficacy trials. They do tend to favor funding innovation over dissemination. And finally, the publish or perish culture, where researchers are more likely to choose studies that are quicker to do and where they can publish quicker because it helps their career advancement. So there is little incentive to conduct dissemination or scale-up studies that cost a lot and a longer time to complete it. So if I could leave you with one key message for today, is that if we are serious about actually having an impact on the population, we need to be doing more dissemination or scale-up studies. We need to be shifting our focus away from descriptive studies to intervention studies and much more towards the right side of this diagram, which is dissemination studies. So I'd like to pose a challenge to you today. We know what to do, but how do we do it? How do we convince funders to start investing in dissemination over innovation? How do we convince them to invest in their previous investment of innovation that we know works to actually scale it up? How do we as researchers and policymakers make a difference in the population? We conduct more dissemination research. How do we change the culture? So lastly, this is a screenshot of the paper if you'd like more information, and my contact details are there. And I would like to thank all my co-authors on this paper and yourself. Thank you.
Thank you so much, Karen. That was wonderful. Now, we don't have time for questions for Karen, but she will be here in the networking time. So please seek her out and ask her what questions you have. Right, so now it's my pleasure to introduce Professor Heather McKay. Professor Heather McKay is a professor in the Faculty of Medicine in University of British Columbia in Canada. And she has been working in implementation and scale up for more than 20 years, or about 20 years. And so she's got lots of lessons to share with us today. So welcome, Heather.
Thanks, everyone. Hi. And am I projecting back? Am I projecting too much back? Yeah, you're not running out. So that's always the good first sign. Thank you so much for being here this afternoon. I've had a wonderful 3 months actually in Australia, and a very productive last week here in Sydney with some very wonderful colleagues. And I learn as much, I think, as I share about what I have learned over the years, and every interaction is very valuable. I think I've met many of you in groups or one-on-one over the last week. So thank you for being here tonight. Afternoon. I'd like to also acknowledge that the work that I do in Vancouver, British Columbia is on the unceded ancestral territories of the Tsleil-Waututh, Squamish, and Musqueam First Nations people. And I feel very privileged to live, work, and play on those lands. We've all heard about the gap in moving research into practice, and it's 17 years or so, depending on what you read, and much of research, evidence-based research, never ever moves into practice. And I am less interested in that, and where I've animated the red circle there, I'm much more interested in what Karen said we have to do more of. I'm way more interested in how we take trials that we show have been effective in randomized controlled trials and put them into practice at large scale. So that's where I spend most of my time. And I don't even need to talk to this slide because Karen just convinced all of us that scale up matters. So that's fantastic. I'm going to zip right through that one. Before I go on, this is a little bit of participation. So of those in the room, I'm going to ask if you would you self-identify as a beginner? I don't really do scale up. I don't really study scale up. I'm interested in it or I wouldn't be here. If you classify yourself sort of there, could you stand up, please? Oh, please, some of you I know, this is not you. Yeah, so interested in learning more about implementation of scale up, but not actively researching that. I'm competent about, I'm pretty competent. I do some scale up studies. I've scaled up some intervention trials, but I still have a lot to learn. How many have dabbled in implementation and scale up trials? Yeah. I think we have a lot of humility in this room. My goodness. And then the last group is, oh my God, I should be giving this talk. I've done so much of this. Anybody would see themselves as knowing quite a bit about implementation of scale up and the study of both. Okay, thank you. Karen didn't define scale up, so I will. And what our team means by scale up, and you're going to see just different definitions of this term, is written here. So this is very simply speaking, I'm going to take an intervention that I've shown works on a small scale. I'm going to look at this very complex system in which I'm trying to put it into place on a larger scale to see if it can still work. And putting it into play on a larger scale is messier business, in my view, than designing and implementing a randomized controlled trial. I didn't see a lot of people in the room who would define themselves as implementation scientists, and some don't like to use that term regardless. But I felt compelled to entertain the difference, in my view, between implementation and scale up. And very simply speaking, scale up lives within implementation. I can implement an intervention, a practice, a policy without scaling it up. I'm going to just get one hospital, get all the surgeons in one hospital to wash their hands. That's all I care about. Just that's one hospital. That's my focus. I'm never going to scale that up. Or I can say I really need to get every surgeon in every hospital in New South Wales and probably Australia to wash their hands when they're entering a surgical unit. That's my scale up model. I can say in New South Wales, in one municipality, in 10 hospitals and so on, but some sort of movement towards having a population level effect. You can implement without scaling up, but you cannot scale up without implementing. This is really for researchers that study implementation and scale up. And it's really lovely to think that, as Karen suggested, we're going to do a pilot study, and then we're going to do an efficacy trial, and we're going to show that our intervention works. And then I'm going to scale it up a little bit, and I'm going to test it. I'm going to scale it up again, and I'm going to test it, and so on. And I will tell you now, that seldom happens. Many pilot studies go straight to scale up, depending who your partners are. If they're government, anybody from government here before I say, oh yeah. Yeah, so sometimes there's another agenda where you do a pilot study and you have to move it right into large scale because there's some expectations to do so. Others go from efficacy to scale up. Lots of efficacy studies never go to scale. Most of them, in fact, Karen has just told us that. But I would argue that even though we have this amazing intervention, this amazing practice, or a great policy, it isn't put into practice or put into play or scaled up by themselves. There's a process in doing that effectively, and there's a process to evaluating how to do that effectively. And I would argue that that's important. And I would also suggest that it's important at two levels. On the one level, on the box on the left, the innovation, also called the intervention or the practice or the policy, we want to know what the contextual factors are that are going to support or impose upon putting that innovation into practice. At the level of scale up, now I'm bumping up a level, and I want to look at all of those factors on a systems level, like implementation, organizational delivery partners. What is in place and what is not in place to work with me to implement my innovation at broad scale? I'm evaluating my innovation at these two levels. Can I implement it to participants effectively? And can I scale up in partnership with many diverse partners effectively? I'm evaluating at both of those levels. And I'm telling you this because it took us a long time to figure out some of the complexities of this. At the level of understanding how we implement our innovation at scale, we use various implementation strategies. And these are implementation strategies that usually a central support unit will use to work with organizations, whoever it is, that is trying to effectively implement the innovation at scale. I'm just defining that because you don't see that defined the same way. And some of the factors of the implementation strategies that have been reported to affect scale up are shown here. So what are they? A cascade and phased approach to scale up. You start small, you move up across a phased scale up to reach broader scale. It is absolutely essential in most conceptual models of effective implementation and scale up that you use local implementers. You have to engage individuals who at the end of the day are going to own and be the architects and the deliverers of your innovation. They need to be engaged. It needs to be a simple intervention, although its implementation can be complex. Simplicity matters. Political will, I work a lot with our Ministry of Health, and we change the priorities of what we're doing based on how their priorities are changing. We do our best to align what we're doing in terms of health promotion and prevention to align with the language that they're using and the priorities at any given moment. And finally, although depending on who our partners are, our funding partners are, not everybody loves in-depth research, but everyone likes to see the results of our innovation and know that it's working. So we always apply for and are often in receipt of funds to do an in-depth research project to see if our innovation works and implementation strategies that support it while delivering the program with our funders, money. Going the wrong way. So I'm just going to. So this really sums up sort of the process of implementation, going from small to large scale. So if you think about the innovation or the intervention, and this is from Kieran. He has taught implementation science for years and was really frustrated at how difficult these concepts were to grasp. So came up with this very simple model and said the intervention is the thing. Effectiveness research looks at whether the thing works. Implementation research looks at how best to help people and places do the thing. I talked about delivery partner organizations. We're helping them. If they're meeting the needs of seniors, we're helping them deliver the innovation. If it's schools, I'm helping the schools, the teachers, the principals deliver the innovation. I'm not delivering it. I'm working with those delivery partners to get it into play. And implementation strategies are the stuff we do to try to help our delivery partner organizations do the thing. So those are the different levels that we're talking about here, that I'm talking about here. And this is, oopsie-daisies. And this is just us aligning it to choose to move. So I'm going to talk about choose to move in a minute. So what you're about to hear from me is that choose to move, our intervention for older adults, health promoting intervention for older adults is the thing. We want to see if it increases physical activity, if it increased mobility, if it decreased social isolation and loneliness. That was our goal. Could we implement it effectively enough that it worked? And the implementation strategies that we use to get our delivery partner organizations ready is training, technical support, and so on. there weren't many people in the room, although some of you did not tell the truth, who are evaluating interventions at scale. But I do believe the scale up still lives in what I'm calling the too hard basket. It can be really complicated when you get into the implementation science literature. And the reason I know this is not only because we just heard about that from Karen, but a doctoral student working with me, Samantha Lee, did a study also. She did a systematic review of the physical activity in older adult literature and found that within that literature, just go here, 8% of those interventions cited an implementation or scale-up framework that was guiding them to deliver their intervention, to implement their intervention. Only 4%, and this is consistent, Karen, with what you just said in the overall physical activity literature, only 4% are ever scaled up. My husband, poor thing, works with our Canadian Institutes of Health Research, and I'm on him now all the time about why are you funding studies that will never go to scale? Your job, your mandate within Canadian Institutes of Health Research and within the Federal Ministry of Health is to improve the health of Canadians. You cannot do this if you're funding one-off studies that will never go into practice at large scale and have a fighting chance of improving health at a population level. You heard a little bit about this from Karen also. Scale-up's confusing and sometimes too confusing, and there's a vast array of frameworks, theories, models, and indicators. And Karen said there's hope on the horizon because a lot of this work has been done, but this is conceptual and not enough, in my view. Researchers from around the world have done the hard work of taking all of these models and putting them into practice, to applying them to really difficult studies in the community and seeing how these frameworks can or cannot be applied. So there's lots of stuff out there, and here's some of them. In 2012, Rachel Tabak identified 61 frameworks that support implementation. Do we need 61 frameworks? I'm not sure. Laura Damshorter identified 39 factors that affect implementation. Will we measure them all? Do we have the rest of our lives to do so? No, we kind of don't. Are there 10 maybe that we could be looking at? Byron Powell, 73 discrete implementation strategies, and Proctor's 17 outcome domains. So as a trainee or a student just entering this field, this is daunting. This is a lot to take in and to find your way through. So we tried our best, and I'm no implementation science expert by any stretch of the imaginations, but we conducted a Delphi project with an international group of self-claimed implementation science in physical activity and behavioral nutrition. And we asked them, could you tell us, please, the implementation frameworks that you find most useful and use most often, the implementation indicators, determinants, and outcomes that you use most often and find most useful? And can that then become a starting place for those who are wanting to do implementation research so that they've got a little bit of a roadmap? And I'm not going to go into this, it's way too sciencey, I think, but take a look. So those of you who are working in this area, please take a look, and it can guide you in some ways if you're interested. We hoped to do that. So I think there's another circle is going to come in on its own whenever it feels like, so we'll wait for that. But as you're moving along the scale-up continuum, so if you look at the top, as you look along the scale-up continuum from small to large scale, our focus of our evaluation changes, and Karen just talked to you about that as well. So at the very beginning, I really want to know if my innovation works. Does my intervention work? I'm going to control everything, and I'm going to make sure that it works. It increases the mobility of older adults when I put it into play. As you shift, if you shift towards larger and larger scale, you become way more implemented within this very dynamic, complex system, which factors have to be in place to implement it at broader scale. So the focus of the evaluation isn't so much does it work, but how do I get an innovation that I've shown works into practice on a large scale. There it is. See what I tell you? It's just a bouncy thing. So moving in the last part of my talk into the project that we have worked really hard on, which I think is fundamentally important, given the stats right now that 20% of older adults in Canada, but I believe it's consistent around the world, are feeling very isolated, and it has been called the loneliness epidemic. In addition to that, we know that in Canada and probably elsewhere around the world, 85% of older adults do not meet physical activity guidelines. Now that's called the physical inactivity epidemic. So we have these two sort of converging problems that need to be solved, in my view, as it relates to older adult health. So we got together a bunch of community partners and researchers, and we developed Choose to Move, which is very simply defined as a health promoting intervention for older adults who were self-identified as being physically inactive at entry. As much as we would like to make this available to all older adults, we didn't really need the marathoners in our program. They were doing okay. They can continue to run their races. We don't want that. This was physically inactive. The Ministry of Health is our partner, so they could engage in this program free of charge. So there was no charge for any older adult to engage in Choose to Move. And the components of Choose to Move are listed here. So an older adult will work with an activity coach and in a one-on-one consultation, come up with an action plan, physical activities that they like and want to do, with the idea that they will then maybe stick with them over time. Motivational group meetings, depending on which phase of Choose to Move we're talking about, between 6 and 14 older adults who encourage each other to stick with their action plans and their activity coach. So this is the part of the intervention that was designed to increase social connectedness, and they did become very, very, very attached to both their activity coaches and others in their group sessions. And there's information that was shared about nutrition and other things, but a lot of it was really, you know, how are you doing? How are you doing in the activity program that you chose? We were initially doing telephone check-ins with older adults, but I'll show you how we've adapted this over time. And our newest phase 4 models, we've taken out the telephone check-ins based on our adaptation evaluation. We've added more group meetings as they liked that. Nobody liked the check-ins, and it's also reduced costs, which was our funders' request. Can you get the costs of this model down? So our Choose to Move model is the Choose to Move program. That's the innovation and the implementation strategy. So what we do is we recruit partner organizations that serve the needs of seniors, and we do our best to integrate Choose to Move into what they're already doing where possible. We train them up, we offer them technical support. So our focus becomes on helping these organizations get ready to implement Choose to Move, and then to do so once they feel they've got the skills they need to do that. I don't think I need that one. Our role has evolved over the years, but initially the active aging research team that I lead at the University of British Columbia, we served as a central support unit. But now we're working with the Active Aging Society that gets these other NGOs and not-for-profit organizations who are serving the needs of diverse groups of seniors, different sociocultural groups, men's groups, and so on. And they're actually working as a central support unit to support these organizations to get ready to deliver Choose to Move. And the central support unit is very, very important. And it's interesting because our government has said, do you need this group? Once you've got Choose to Move in play, do you really need these guys go? They're costing us a bit of money. And the answer is yes, you absolutely need a central support unit for the life course, in my view, of the intervention, and A. Wandersman's work would probably support that. What's their job? It's to adapt to the political, social, and cultural ever-changing environment within which Choose to Move is being delivered. The Central Support Unit listens very carefully to our delivery partner organizations and responds to their capacity or lack of capacity to offer them the training and support that they need to deliver Choose to Move. Those in the Central Support Unit must demonstrate credibility and flexibility, but not in science, not as researchers. They have to be trusted and credible within their community as community activators and community influencers. And then I've already mentioned central support and training. So Choose to Move has been scaled up across 8 years with consistent support from our BC Ministry of Health. And I'm going to get to the top part later, but just showing you beginning in 2015 to present. I'll get to the numbers as well later, but just we've been fortunate to do a pilot study and then using a cascade or phased approach that we know from the literature works, been increasingly implementing Choose to Move at increasingly larger scale. I'm going to go right past this one as well. At the very last slide, it talks about lessons learned, and this is going to come up again. And those of you that have talked to me or with me over the last few days know that I go on about this, but partnerships are the lifeblood of implementation and scale up. Partnerships are absolutely the heartbeat of everything that we do. So these can be your partnership with community organizations, our partnerships with our health authorities, our partnerships with our Ministry of Health. And in the past, I've worked in schools with the Ministry of Education. So partnerships are key, and trust is the cornerstone of partnerships. And there's quite a good literature on that now. And it takes time to build trust. You can't go into a community and turn something around in a month or two. It takes a lot of time to build trust within that community to actually be effective in getting your innovation into play. So we evaluated Choose to Move using, for phases 1, 2, and 3, using a type 2 hybrid effectiveness design. And I'm not going to spend too much time because not everyone in this room is a researcher. But we had in the early phases for Choose to Move, we had a 3-month active phase where participants, older adults who were inactive at baseline, older adults was defined as, those kind of over 65, but if we were approached by 55-year-olds who had mobility limitations, they were invited into the program. So 3 months intense phase with their activity coaches, and then a 3-month maintenance phase. After our adaptation evaluation, as I already told you, we shortened the intervention to 3 months and added group sessions. And here's our results in a nutshell, 8 years later, one slide, gotta love it. So we showed in phases 1 and 2, a significant increase in physical activity and mobility in older adults who engaged in Choose to Move. We showed a social connectedness increase and loneliness significantly increased. All the things we had hoped to see, we actually saw happen. So it did in fact work. How many of you have heard the term voltage drop as it relates to research? So the idea as I get further and further away from the power source or the design of the intervention as planned, my results will diminish over time. So we were really interested in our phase 3 evaluation whether voltage drop occurred, where we're going to see the same magnitude of change in those outcomes I just told you about, physical activity, mobility, and so on, or were we going to see it drop? In the voltage drop literature, Chiz's Chambers published in Implementation Science a few years ago, a decade ago now, I guess, that on average, the average voltage drop for innovations in health systems research is about 60% on average. So what did we see? So if we look at our phase 3 results, and so we actually evaluated our data in 2 age groups, 60 to 74, and then those greater than 75 years old. For physical activity, we saw 53% of the effect we saw in phases 1 and 2 was maintained at larger and larger scale. 53% of the effect in mobility was maintained. You can look at the results yourself for the 75-year-olds, 97% for physical activity and so on. we think, although we didn't do any sort of mediation analysis to confirm this, we added more group sessions and gave older adults more chances to get together. We saw 122% of the effect in phase 3 that we had observed for decreasing social isolation in our early phases. And in the older group, that was about a threefold increase. That was a threefold increase in the decrease. That is so confusing in social isolation. So there's a voltage drop, but depending on how you adapt your innovation, there can also be a voltage surge, in my view. And then there's the results on the bottom for loneliness. So the reach of Choose to Move has been significant. And again, we could not do any of this without our partners. And we're all over the place in the province of British Columbia now. 757 programs in 90 community. We've trained 283 activity coaches. And this number has gone up since I presented yesterday. See how fast we just get this stuff out there. So we're continuing to implement 7,400 older adult participants across BC. And this is for those who are interested in implementation science in the room, but the constant bothersome part of implementation of scale is that you're going to have to adapt to the capacity of your delivery partner organizations to deliver. You can't, and even if you want them to deliver your intervention exactly as you have trained them to do and as your implementation strategy suggests they should, they're not gonna. They're going to do this the best they can with what they have. So there's this constant tug of war, if you will, between adaptation and fidelity. As researchers, we want them all to do it exactly as we designed it. Can you just, and as practitioners, like, no, we really can't. We don't have the capacity to, there's just me in this organization, and we're a small not-for-profit. I can't do it in that way. So constantly looking at this tug of war. I'll just give you a second to read this, but this is the definition of adaptation that we use. And the whole idea is that you actually adapt the design or delivery to improve it in some way so you can get it into play in different contexts, different settings, and with different individuals. Whether you like it or not, adaptations happen. This little line at the bottom, they're purposeful. We plan to adapt, as you saw, we did over those years, or they're unplanned. And your job is to monitor both of those things if you're evaluating this. So back to that adaptation slide. So the dark blue arrow shows where we conducted a formal adaptation and a formal adaptation evaluation process between phases 2 and 3, just to understand the best fit within different communities and with different delivery partner organizations. COVID affected us all, and the group that we work with, the community-based senior service sector, we affectionately call it in Canada, they were decimated. They were decimated by COVID. They had none of the resources they had previously. Nobody was meeting in person. Everyone knows this story. We were all affected in very profound ways. So we very quickly adapted Choose to Move to be delivered in the virtual environment. And we had older adults in year 2 of our innovation who had not left their house in like 18 months. And so we thought it was really, really crucial to adapt and deliver this in the home environment. And then our phase 4 adaptation was working with our government and community partners to decrease the cost where we could of delivering Choose to Move. Why are adaptations necessary? And I'm going to tell you this little story. I'm just about done. Yeah. Tell you this little story just to drive it home. And so we have a community group in Babine Lake in the very northernmost part of British Columbia. It's beautiful on the right, but not so beautiful on the left. It gets really cold up there. The population is 337 in 2021, and that's an 11% increase from the 303 people that lived there in 2016. It was famous for its ice hockey team that was in the Pacific Northwest Hockey League until that league folded. So now it has no claim to fame that I'm aware of. Compare that to the city of Vancouver, where I live. 2.6 million people in Greater Vancouver, the highest population density in Canada. one of the most ethnically diverse cities in all of Canada, and one of the most expensive cities, along with Sydney, in which to live. So we worked with the village of Grand Isle and we said, well, how do you want to do this? I mean, they don't have a rec center. They don't have a trained activity coach. So we were listening very carefully with how those in the village of Grand Isle could deliver Choose to Move. They decided that they would deliver the program in their municipal hall. Might not have been used for anything else, potentially. They came up with an advisory board. They worked with their community health clinic to let every older adult know that Choose to Move was available and free of charge. So working with the community health. And then they adapted the Choose to Move program itself. So it had content that was relevant, interesting, and important for those who lived there. So it was adapted in that way. They were having a lot of trouble with transportation, especially in winter in the village of Grand Isle. So there was one person who had a van who did all the pickups of the older adults. There's probably 7 of them. I actually don't know how many there were, but to get them to the Choose to Move program. And that's really just to drive home the diversity. We're doing cultural adaptation, ethnocultural adaptation to honor the differences in different cultures, Indo-Canadians, Asian Canadians, and so on. All of this is important in order to recognize these differences and make the program, in this case, Choose to Move, more relevant for them. And this is my last slide. So the lessons I've learned are many over the last 20 years, and some of them are here. And I've already told you about authentic partnerships. I don't use that word lightly because I've spent a lot of time getting to know and understanding the needs, the limitations, and the pressures on especially our funding partners. So these authentic relationships are important. Ongoing communication is absolutely critical. Program champions are essential. I've made peace with adaptations. They're inevitable. Even if you think it's not going to happen, it's kind of going to happen. So our job is to come up with approaches whereby we're evaluating and monitoring how these adaptations are occurring so that we can interpret our results at the end. And I'm a researcher, so of course I'm going to say this, but having evidence as a part of, a tool in your toolkit to share with your funding partners that you can implement your intervention successfully. And yes, it does work to meet some of to change some of the health outcomes that are so important. And finally, I'm just going to zip right to the last one. And I said this today in the seminar with the group is, I always begin with the end in mind. So in terms of partnerships, in terms of the work that I do, if you're to take away one thing, and if I'm to remember one thing as I'm doing my own work, is I need to know where I'm going in order to start the process of getting there. So I need to know, as I'm designing the intervention, who my partners are going to be after it's designed, and I'm going to bring them in right at the start to provide me with input as to what the innovation needs to look like and what implementation strategies need to be in place in order for them to be able to deliver it later on. I do all the talking for my team, they say, and they do all the work. So I am so privileged to work with a very, very talented team at the University of British Columbia, and their names are listed here. And thank you so much for being here this afternoon. Appreciate it.